Well, good afternoon, everyone. I'm Olivia Henze from the New England QIN-QIO, and I'll be moderating today's webinar. Thank you for joining us for Local Agencies Share Advice on Succeeding with Cardiovascular QAPI. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how to unmute your line. Or you can pose a question in the chat box. At this time, I'd like to introduce today's hosts, Doreen Badad and Georgette Heli. Doreen is the main home health lead for the New England QIN-QIO. She has over 20 years of experience in the healthcare field, specializing in quality improvement and project management. Georgette has more than 30 years of experience in healthcare. Her varied background has included working in hospitals, primary care, skilled nursing facilities, home health care, and quality improvement. Doreen, I'll pass this over to you.
Thank you, Olivia, and good afternoon, everyone. Thank you for joining us on this beautiful spring day. And Olivia mentioned in introduction, we are the New England QIN-QIO. I work for Health-Centric Advisors, and Georgette works for Paladine. Our two organizations join together to form the New England Quality Innovation Network. We partner with and assist providers in all settings of care with offices in each of our 6 New England states. The New England Home Health Collaborative is part of the work we are doing under contract with CMS. Next slide, please. It's now been about a year since most home health agencies joined the Cardiovascular Initiative. Since that time, we've been working to include more information and resources on our website. We want to make sure that you know where to find us. Our web address is here, www.healthcarefornewengland.org. Next slide, please. When you get to the website, on the main menu, you'll see a tab for providers. If you click there, then you scroll down to home health, you'll find information on the 3 home health initiatives, the Cardiovascular Initiative, Transitions of Care, and Medication Safety. You'll also find information and links for our current and past webinars, project resources, and our monthly ICYMI newsletter for home health agencies that I'll be talking about a little bit later. Please remember that this information is out there to facilitate your work in this initiative, so we welcome your feedback on our website anytime. So please, if there's anything that you would like to see there that would help you with this work, please let us know so that we can bring that to you. Next slide, please. One of our goals this year is to bring you more peer sharing opportunities, and toward that end, we're dedicating today's program to just that. We are very happy to have 3 agencies participating in this collaborative who are willing to share their advice and experience with you about implementing cardiovascular QAPI. The 3 agencies that you'll hear from today have all been actively submitting data to the Cardiovascular Data Registry for many months now, and through a generous and gracious spirit, they're here to share their successes with getting started, overcoming barriers, lessons learned, and provide you with some key takeaways. At the end, we hope that you'll take advantage of the opportunity to ask questions and have further discussion on success with cardiovascular QAPI. Next slide, please. And now I'm going to turn this over to my colleague Georgette, who will introduce our panel today and start the discussion.
Thanks, Doreen. Hopefully everyone can hear me okay. I'd like to introduce our presenters from the 3 agencies and thank them so much for being here with us. The first person we have with us is Michelle Holst-Grubbe. She is the Wellness Service Coordinator from Salisbury Visiting Nurse Association in Salisbury, Connecticut. Next, we have Jennifer Gullison joining us. She is a chronic care specialist and also the Clinical Director with Cornerstone DNA of Rochester, New Hampshire. And finally, we have Alicia Mooney, who is the Manager of Advanced Illness and Wellness at the Community Health and Counseling Services in Bangor, Maine. Next slide, please. So Salisbury Visiting Nurse Association was founded back in 1904. It's the oldest and most comprehensive home care agency in Northwest Connecticut. They serve 11 towns and have an average daily census of about 100 patients. They provide home health care, home assistance, hospice, and palliative care. They also have community care services, which include a variety of different opportunities, including matter of balance classes, wellness clinics. They offer flu immunizations and clinics, and that includes the pediatric population. Also, the Salisbury VNA has been awarded the Home Care Top Elite Agency Award over the past 3 years. The Top Elite Agency Award identifies the top 25% of Medicare-certified agencies, which is about 10,000 nationwide, so that's quite an accomplishment. Next slide, please. Some of the highlights for Salisbury VNA have included, they've actively been submitting their data for over a year now. They selected blood pressure and smoking cessation as their measures, and some of the things that they have implemented have included bulletin board displays for their clinicians. They've offered educational handout packets for both clinicians and patients. The clinicians were able to participate in a webinar, The Health Impact of Tobacco Use and Cessation, and they also have plans in the making for a smoking cessation continuum. They're also actively engaged with Home Health Quality Initiative and the Million Hearts campaign. Next slide, please. Cornerstone VNA provides services to patients in Rockingham, Stratford, Belknap, and Carroll counties here in New Hampshire, and also York County in Maine. They are a medium-sized, independent, nonprofit home care agency, and they provide home care, hospice, palliative care, and life care, which is a private duty services. They have certified specialty services as well as standard disease management programs. Their technology programs include telehealth and personal emergency response systems. They too received the 2015 Home Care Elite Award, and they're also a 4.5-star agency for patient outcomes. Next slide, please. Some of their highlights have included they've been actively submitting their data on smoking cessation since June of 2015 and blood pressure since September 2015. They've been doing work with the tobacco specialists from the New Hampshire Tobacco Prevention and Control Program, and they've also worked with the Physician Association of Rochester and the Million Hearts campaign. They are also providing smoking cessation resources for New Hampshire and Maine, and they've created a customized referral form for New Hampshire patients to access smoking cessation resources and products. They also have customized education within their EMR system so that they're able to provide patients with different brochures and pamphlets on some of the activities they have going on. Next slide, please. Community Health and Counseling Services out of Bangor, Maine is a nonprofit freestanding Medicare-certified home health and hospice agency serving 6 counties in Maine. The agency is unique in that it has adult and child mental health programs throughout the state, including 3 behavioral health homes. They implemented a chronic disease program which included the use of telemonitoring. They're also a recipient of FOSSI's NCAP Top 25 for 2015, that's HCAPS actually, and they received a 2015 Home Care Elite Award as well. Next slide, please. Some of their highlights have also included actively submitting data to the registry for over a year. They have been working on the blood pressure measure as well as appropriate use of aspirin. They have identified opportunities to improve their practice with blood pressure monitoring, and they're also in the process of implementing best practice for blood pressure monitoring under the Population Health Management Philosophy agency-wide. They also received recognition from HHQI for being one of the first 3 agencies to achieve milestone number 4 with this project. Next slide, please. So without further ado, we're going to get to our channel, and we're going to talk a little bit about the workflow process, how they got started, what they did internally to get organized. And I'd like to pass this off to Jennifer from Cornerstone. If you could go first, please.
Yeah, absolutely. So we got started back in June of 2015, and we really got involved because Georgette was a lead for us from our local QIO, looking for home care agencies who wanted to get involved with this initiative. We were hesitant in the past because as most home care agencies were very busy and we had a lot going on, but we are committed to quality and really felt that committing to this initiative would only bring better quality of care and education to our patients. So that's really how we got started. And Georgette was an excellent resource coming out to our agency, meeting with a core team from our disease management team, which is a multidisciplinary team, to really look at the workflow, how the data is collected, and we chose the tobacco cessation as our first measure to get started. And that led us to collaborate with the New Hampshire Tobacco Association, who is key to come and provide education to our staff. But we really had to look at internal workflows to see if we could easily implement this. And we use Allscripts, which is our EMR system, and it allows us to customize and to tweak interventions because part of this initiative is that you have to do the data collection and the reporting for key measures on a monthly basis. So we had to really look at our Allscripts EMR system to see how that would work, what type of customization we had to do, and it really wasn't that much tweaking to be able to consistently report on a monthly basis those measures. Our second measure was blood pressure control, and again, we had to do the same process, and agencies need a key person to be able to lead this, to know that someone consistently is going to monitor this, to collect the data, and to be able to report off, and to assist with staff education and getting staff buy-in. And we really were able to get the staff buy-in by promoting that this is for our patients, that this is a national effort for the million hearts, and to improve the outcomes of all of our patients and to provide quality of care. So the buy-in from staff was not difficult at all.
Great. Thanks, Jennifer. Can we move on to Michelle from Connecticut? Maybe Michelle's not with us. Let's try Alicia. Michelle, are you there?
It's Olivia. Michelle, just make sure to take your phone off of mute if you have it on.
We now?
Yes, we can.
We can hear you now.
Hear me? I'm talking to
Michelle, Michelle, yes, we can hear you. Can you go ahead and tell us about your getting started?
I did, okay. I was giving this project because I felt as the wellness service coordinator that it kind of fell under my auspice of health promotion and disease prevention, and having had some experience with QI in the past. So we kind of got started with an educational rollout after I actually did the webinars to get educated about the process. And I had to find a way to really engage the staff because, as I said, people wear many hats here. So I had an educational session where I put together an introduction to the Million Healthy Hearts campaign. Everyone registered, and I gave an educational handout packet. I did concise handouts for patients and concise educational handouts for the clinicians. And I ensured them that all these would be available in a geographical space where they would see them, so they had extras to give to the patients. I was trying to make it as easy as possible for the clinicians to stay engaged. I had also done a bulletin board a month ahead of the educational session to kind of introduce them to the concept that this was even coming. I felt that we wanted to expand it to the entire community, so I took it beyond the Medicare patients, and I actually think this gave more buy-in to the clinicians when it became a bigger program for our agency. I took it to all the community events that we were present at, all my wellness clinics, all our Matter of Balance classes, and also into the daycare settings and the after-school programs as a nursing daycare consultant.
because I felt I wanted to engage the younger population as well as the staff at the daycare centers. And I did this by putting together educational handouts that were in the HHCQI B-tips, and I kind of customized them to the HHCQI and ourselves. And I made them very specific each month at each clinic. And I've actually had some good success from people in the community with their feedback verbally to us. So then I thought, how do I streamline this process? So what I did is I kept it all under my own auspice, just one person in charge, and I made a procedure that all the clinicians were given, and for each person who takes intake, which could be a variety on any given day, all were given the abstracts to attach to the patients who came with a diagnosis of blood pressure, high blood pressure, hypertension, because we started with the high blood pressure criteria. And that way, it was triggered that they had to fill that out. The clinician would fill out the general patient info, and then it would come back to me. We decided to keep it in one central spot, and it would come back to me as the agency lead on this campaign. And then when those discharges came up, I would abstract the data. And we eventually did embed it within the EMR as a way of improving our documentation. We recently just added smoking cessation, and we're still kind of working on that one. We're trying to embed that again in the EMR, and we are trying to work on a smoking cessation continuum. What that means from the time the patient is in the hospital, goes to long-term care, and then comes to us, that we're all on the same page in addressing this patient's addiction to nicotine, and that it's been addressed right through until we see them in the home.
Thank you, Michelle. And Alicia, last but not least, can we hear from you?
Sure. We got started when we received the notification from the QIO about the project, and we decided we were in the process of implementing our chronic disease program and updating our clinical pathways, and we thought this would be a great fit for our department to look at and to incorporate for best practice. So we took some of the educational components that they had provided dealing with hypertension. We chose to do the blood pressure monitoring in addition to the aspirin use, and develop those into our pathways and took them across all of the disciplines for our Medicare patients. And we were able to make some changes in that and provide some good education as well. Extracting the data for us is a little challenging because it is manual. We do have an EMR, however, it is very difficult to have customized reports run for the application that we have, so it is a manual process. And so the office does fall under myself and working with our QI department. So there's three of us, but I am the champion for that. We share it throughout our management team. We disseminate it down to our clinical staff, our end users, and really make sure that we're delivering the best quality of care and education in dealing with the blood pressure management and the aspirin use for our patients. We have a fair amount of joint replacement patients that we do who come to us with a secondary diagnosis of hypertension, and we found some opportunities to be able to improve their outcomes and their care with the aspirin utilization with us.
Thank you, Alicia. Next slide, please. So, this is a great opportunity for those of you that are signed up and working with us and struggling with maybe starting this project. We're going to talk to each one of the agencies about some of the challenges that they may have faced and how they overcame them. I'd like to start with Michelle from Connecticut, if I could.
Thank you. Yes, we certainly did have our barriers and challenges. One of them was kind of a break in the fluidity or momentum of the campaign, partially due to we encountered, as all do in the summer, vacations, and we had some per diems that worked primarily in the summer, so it was capturing them and educating them. So there were some problems in that sense and regard. Secondly was the documentation. I knew the conversations were occurring, just when I was abstracting, the documentation was not there to support that. So we embedded the interventions that I had identified for blood pressure for the staff to be teaching their patients. We embedded them within the care plan under the cardiopulmonary care plan component. And once I did that, the documentation improved readily. So that was sort of an immediate response once we got it through our EMR administrator to put it there. And for myself, I think the barrier that for this campaign from the beginning and through to however long we do this will be actively keeping the clinicians engaged. And I think that kind of leads to me being the cheerleader of sorts, but also I had to prove relevancy to them. So when I did the rollout with the staff education for smoking cessation, what I put in the package that I wanted to prove relevancy is in the report section under data. For each agency, they have the cardiac risk report cards for your population based on the information that they have at hand. And when I showed that to them in color, I said to them all, do you see the relevancy of this project now? And that visual aid was very successful, and many of them remarked about, yes, this was important for our patients, important for their outcomes, important for their health. So that, I would have to say, was what I call the aha moment in this campaign and keeping the clinicians engaged.
Thanks, Michelle. Can we move on to you, Jennifer, from Cornerstone?
Yes. So as far as overcoming barriers, our biggest barrier was the data submission. We had it very planned as far as the education we did. We had it videotaped so clinicians that were not available could actually watch it and be up to date on all the best practices and the specific process that we had rolled out. But the data submission was the hardest for us because if you have the person that's in charge, the agency administrator, fortunately she does work and has worked at the agency forever, so areas that we had as far as logging in, she was able to help us with. But one of the key tools that we actually found on the HHQI website was the HHCDR overview webinar. And that really helped us to be able to say, okay, this is how we log in, and now that we get the abstracts for the data collection, this is what we do with it. And on the HHQI website, they have a process flow chart and also an abstract tool. And those tools really helped us to be able to understand exactly what we had to do once we got the reports. And then we, like I said in the beginning, in our EMR system, we actually embedded certain language so that our staff educator, which does the chart reviews, knows exactly where to look. And if there were any issues with documentation, we would have to go back to the staff to say, you didn't use the correct template, which is what we need to be able to abstract the data. So once we figured out where the data was missing from the clinician side, we were able to do re-education, and it improved significantly. So it was making sure your EMR system has the data you need and you know where to look for it in there to be able to accurately report it once you submit it.
Great, thanks, Jennifer. And Alicia.
I think our data extraction was one of the most challenging things that we had to do because it is manual. One of the things that we did discover along the way was we have multiple branches, and we did identify that we were not capturing all the branches. So we did have to register each branch separately, and so that each generated its own account at that point. But as I had stated before, that it is a manual extraction, so we could not run the reports to pull for just blood pressure management or just aspirin use. So it is a little bit time consuming, however, it is very worthwhile because it has allowed us to change our practice to deliver better care, better quality of care, and again, across our team. We had made some changes in how we do our assessments with all disciplines to make sure that we're capturing some vital information, i.e. blood pressure management, that a therapist may be more focused on the hip and the healing process and the range of motion more so, and not thinking about that secondary diagnosis of hypertension. So trying to get clinicians to look at a more holistic point with the patient to avoid having a complication dealing with a cardiac diagnosis and hypertension. So the buy-in and the change in our practice was a little bit challenging, but the clinicians have really done a good job in understanding the importance of that for our patients, especially in light of the rehospitalization efforts that are going on. So it has really tied in well that way.
All right, great. Thank you, Alicia. Next slide, please. So you've all been collecting data for a little over a year, I believe, and at this point, we'd like to know what you've learned from collecting that data, what kind of changes you might have made, or just what you have found out by participating with this project. And Alicia, I'm going to start with you this time, if that's all right.
We've learned, I think, number one, to be a little more holistic in our assessments with all of our disciplines. And if we don't see a patient who should be on aspirin or some type of thinner, to ask why, and to try to train all of our disciplines to look that way, including therapy in addition to nursing. And I think it's taken us to a different level because as we were implementing our chronic disease program, it really melded nicely as we're looking at our patients who were on the telemonitoring program and really gave more strength to that program to support our patients with their cardiac disease, in addition to enhancing our teaching tools, because the resources that have been available to us have been more than helpful. And we are actually, as our slide stated, we're a little bit different because we're part of a larger agency that has behavioral health homes, and we are in the process of looking at how to integrate that best practice in dealing with blood pressure management across our agency into the behavioral health homes. So we, as an entire agency, are adopting the blood pressure indicator to be able to look at the care for all of our patients across the continuum.
Thank you. Jennifer, could you go next, please?
Yes. As far as what we've learned from our data, it's nice to see the change as far as how you improve from before, because when you first enter the data, it's information for patients that you haven't even implemented the intervention on. So you're going to get 0% compliance. And then as you go through it, 3 months to 6 months of putting in a data, you get to see your compliance increase. And we've showed those numbers to our staff through our disease management team, and staff really see their efforts paying off for the care that they're giving. So, this is one extra thing we're asking our clinicians to do, and you really have to get their buy-in. So the amount of educational materials that we've been able to provide to our patients and being able to see that, the smoking cessation, we're providing it to them, and through the New Hampshire smoking cessation program, we can actually see referrals that are happening, and we get linked into those, and we can see that our patients are getting the conversation that happens as far as here are the resources, and now we can help you stop smoking. Whereas before these interventions, it was, are you smoking? Yes, and then we move on to another question. So I feel like we're providing better best practices to our patients through this initiative, and really being able to see the results pay off as far as the compliance with the initiatives that a home care agency chooses is very rewarding.
Thank you, Jennifer. Okay, Michelle?
Yes, I would have to say the same about watching the flow of the compliance to the documentation. Before we implemented it, you were reviewing charts, even when we started, that you had not implemented the program and interventions yet. And there was 0 to 25% compliance in documentation. 4 months in, after the educational session, it was 0 to 50. Once we embedded those interventions in the care plan for the clinicians, it is now up to 83% compliance. And I do feel that we have improved the care of our patients, our cardiac patients. And for many patients, the first 3 or 4 diagnoses that are not hypertension, so we're not necessarily, that's not the focus of why we're there. But since this program has been implemented, it is becoming more of a focus when they're in the home. I did realize recently that my physical therapists, who actually were my champions in actually documenting before I implemented the changes in the care plan, what I found out was it's not a cardiopulmonary drop-down in their care plan menu, so we are working on changing that now in our EMR. So I have to applaud them even more realizing that they were typing this in freely, not in the drop-down.
Great. That sounds great. So what about, Jennifer, have you done any process improvement based on maybe you found something wasn't working and changed things up at all? Have you done anything like that with your work with the project?
We did. So we use what are called clinical note templates that they copy and they paste right into the electronic clinical note, and they just fill in the blanks. So we've had to customize those based off of information that was missing. For example, for smoking cessation, it says, was the patient screened for smoking cessation, and then did the patient receive at least 3 minutes of smoking cessation education? So in the beginning, we made sure that we did the standardized intervention saying that they provided the education, but there was no way in our chart to capture whether we screened them. So that got incorporated into our clinical note template. So we found out through the assessment and evaluation process pieces that were missing that we had to incorporate into the process.
Okay, thank you. And Alicia, have you had any experience where you found you needed to change something because it wasn't flowing properly or anything along those lines?
We actually originally found out that complete assessments at some points weren't being done. So at that point, we provided the data like the other two presenters spoke about. It did much improve with that first set of data collection where it did show the opportunity for improvement. So we showed the staff that overall, and then our electronic medical record did support in the therapy notes as to what we wanted them to document. So it was more of the educational process going back, and then with the re-auditing every month to be able to see that improvement has been marked. We're really about 90 to 95% compliant at this point with all of our disciplines. So it's been a very, very effective outcome in getting their buy-in and the understanding, and they do have a better understanding of why it is important to look past, the one clinical diagnosis that they're responsible for in the patient well-being. So it's been well received and well done by our staff.
Great, thank you. Next slide, please. So again, we want to talk about lessons learned and your key takeaways. We did a little bit of that in the previous slide. I know that we have some rather small agencies that are definitely pressed for having the staff to do just that one more thing. If you could just talk to the lessons learned for staffing and your key takeaways, that would be great. And I'm going to start with Michelle, if I could.
My lessons learned were simplifying the documentation does encourage compliance, which we readied very quickly. Essential to keep the clinicians engaged. As I said, I feel like I'm the agency's cheerleader for this particular campaign. And proving relevancy for the project, and we did accomplish that with a cardiac risk report card for our agency. And I think any QI campaign project, people hear the words QI, and they find it hard to find relevancy to their practice. But by proving that it's relevant to their practice as clinicians was essential. And for me, taking it beyond just the Medicare population made it seem a bigger picture to our agency and to our clinicians. I did notice one thing as I was abstracting, and I came across this fairly quickly as you're looking through these charts. I call it the QI within the QI. You are reading these notes and you're finding sometimes opportunities to improve practice. And that was kind of a nice byproduct, and we've already addressed those under another arena.
Thank you. Jennifer?
Yes, I think the key takeaways that I can't stress enough is, like the other speakers will touch on, it's really about patient care. So even the size of our agency, it's one more thing we had to take on, and it's not something that's mandated. And why did we personally take it on? It was to deliver better patient care. And the staff really, they latch on quickly to anything that they can help their patients get better. And smoking cessation was an area that we didn't have a lot of resources on. Again, it was, they screen for it, are you smoking? Yes, we move on. And now we have resources, we have materials, we can hook them up with resources to get nicotine patches to be able to stop quitting. And they really have seen a return on investment with the smoking cessation. And with the blood pressure control, we've been able to make new relationships with and partners as a result of this initiative. We are part of the Million Hearts work group that's out of Rochester, and that has helped us get better relationships with physicians. It helped us all standardize the education for blood pressure in a pamphlet that we're all going to be using in our community. And so with those pieces right there and getting buy-in from upper management has helped us better control this group of high-risk population. The buy-in was key from clinicians, and really our management has supported and allowed us to make the process changes within our organization. Another key thing is that key person. So we had a staff educator that's been doing this, and she is, again, it's one person for a growing population that we have for clinicians, and she was able to, if she identifies issues, she can follow directly up with the clinicians. She can follow up with me if we have to actually change the process. So having a smooth internal process is key to this to make it happen.
Great, thank you. And Alicia?
Well, I can surely identify with the one person in the smaller organization. And I would definitely say be realistic in what it is you want to collect. Don't collect data just to say that you're collecting it. What are you going to do with it? How is it going to be beneficial for your agency and for your patient, and is it going to be time well spent? And that's what we have found, because it really has improved our patient outcomes and our patient satisfaction, in addition to looking at our readmission rate. And the clinicians have a great understanding of why we want to do this. We're always preaching quality, but they have a much better understanding of why it is so important to do this, and we've been able to change our clinical practice to meet their needs. And it hasn't been such an increase in their time, in their caseload, that it has been a bad experience for them. It has been very beneficial for the small amount of time it has taken them to implement the changes that we've asked. And it has been very beneficial for us, both for the patients and the clinicians and our overall outcomes.
Thank you. Next slide, please. So this is your chance, those of you that want to get started on this project that might be stumbling a bit, but we'd like to provide this opportunity for you to ask your questions and get the experience from your peers. So Olivia, if you could help people with the question part, that would be great.
Yes, no problem. So at this time we'll take some questions, but just bear with me for a minute as I open up the phone lines. It's a couple-step process. So please just hold on one moment and I'll let you know when the phone lines are open.
The leader has turned lecture off and your line has been unmuted. The leader has muted your line. To unmute your line, press #6.
Okay, you should have heard a command that all the phone lines are muted. To ask a question, please unmute your line by pressing #6. Or you may pose a question in the chat box below, which I am monitoring. Again, #6 to unmute your line, or you're able to pose a question in the chat box below. And go ahead, the phone lines are open by pressing #6. We can give it a little time. I didn't know if there was anything at this point Georgette or Doreen or any of our panelists might want to discuss while they have a minute, anything they might want to add, or that might be able to spur a question from our audience. All right, Georgia and Doreen, it looks like we don't have any questions at the moment. Is there anything that, oh, here we go. I just got one, I'm sorry. From Patricia, what has been the response between interdiscipline communication on the education and direction you have provided to your staff between SN and PT, et cetera? Anyone feel comfortable taking that question?
Yeah, I can take that question. This is Jennifer. So we are very focused on interdisciplinary teams, and when we roll something out, we do it across the spectrum. So it's the PT, the OT, the RN, the LPN, and we change the EMR system so that the clinical note templates that I was referring to earlier, it's the same for the different disciplines. So there was really no kickback from anybody when we rolled it out, because that's consistently how we roll out our disease management topics, if that answers the question.
Thanks, Jennifer. Anything else anyone like to add to that question?
This is Alicia, and we do the same thing. We're very interdisciplinary focused, and so it was presented all across the disciplines, and everybody was on the same page, and that's pretty much how we do the same thing as well.
Michelle here. We also interdisciplinary focus, so I rolled this out at our Monday morning meeting for both blood pressure management and smoking cessation, and we're small enough that we see each other coming and going, that we can communicate and keep the educational process flowing.
Thanks, everyone. Remember, if you have any questions, you can post it in the chat box. If you don't feel comfortable asking a question over the phone line, we'll give it a couple, more minutes, just in case anyone has anything that they would like to add.
This is Doreen from the QIN-QIO, and I have a question for our panelists and for any agencies who are listening in that would like to get in on the discussion. It sounds like you made really great use of resources from this initiative and did a wonderful job at integrating those into your care plans and your workflows. And I'm wondering if at any time in starting this initiative, if you were looking at everything that you had to do in front of you and thinking, okay, where do I start, and what resources would be helpful to me, and maybe, it not being quite as clear as you wanted it to be, or maybe it was the opposite, and maybe you found everything readily at your hands because you somehow got to all of the right places on our website and the HHQI website for the use of the VPIPs. Thank you.
Michelle here. I actually found the BPIPs to be, they were very useful for me. I took a lot of tools. I did not include all 100 pages because that would overwhelm a clinician. I extrapolated what I thought was important and useful and concise for them. And there were some other educational handouts specific to the clinician and the patient, but I made them very concise. For instance, with the hypertension, I did for the clinicians the DASH diet. Well, actually, that was more for the patients. DASH diet, tips to cut sodium, what you need to know about high blood pressure. These are all available on the BPIP website. Creating my healthy heart action plan and lifestyle management for hypertension management. For the clinicians, I did the hypertension medication handout, which was very useful. It's about 6 pages long. And then the nursing therapy track and the MSW track, and again, essential BPIPs I felt would be very specific and useful for them. I did the same when we rolled out the smoking cessation.
Great. We've actually received so much good feedback on the BPIPs, and I know when I'm on a national call with the HHQI, I hear much of the same. How about other resources that you might have needed to get started, figuring out how, where to link up and how to get into the HHC, the Cardiovascular Data Registry? Did everything seem clear to you at the start, or did we need help navigating?
This is Jennifer. We did need some help navigating, and it led us to the New Hampshire Tobacco Prevention, and they really were excellent as far as the resources because we didn't know locally what we had for resources, so the BPIP was great as far as standardized education and tools, but we wanted to know, and the majority of our patients are in New Hampshire, so we had a speaker come from the New Hampshire Tobacco Association and speak about the statistics, and within our agencies, live presenters really are key to buy-in for our clinical staff. So we had a live presenter from the New Hampshire Tobacco Association, and then we actually had Tim Ward with our local QIO come in and speak about the blood pressure control, and we were able to develop patient educational resources to be able to give to all of our staff.
That's wonderful. Great example of partnering and collaborating. Thank you. I wanted to mention for any agencies out there that are looking to connect all of the dots in this initiative with the various resources that are on the HHQI website as well as available through the QIN-QIO, that after the start of this initiative, one of our colleagues at the QIN-QIO in Vermont, Jen Gordon, developed a wonderful resource called the Roadmap to Success Implementation Checklist. And it takes you through each of the HHQI milestones in this initiative and shows you, in order to accomplish each of those milestones, what resources are most relevant, and walks you through in a step-by-step process. So whether you're just getting started or even if you have things underway, there might be some things that you have not yet checked out. If you want to, ramp it up a little bit, it's an excellent resource. It's on our website. So I wanted to mention that again. Are there any other questions at this time? Olivia, do you have any other questions in the chat box?
I do not, Doreen. Would you like to move on to the next slide?
Sure, we can do that. And just, before I move on from the discussion part of this, I think we've had so many wonderful ideas and information that was shared today, and I was actually going to do a recap of some of the great takeaways, but I wrote 2 pages, and so I don't even know where to start with that. A lot of good overlap, though. Some of the common elements I heard were creating relevancy and using that relevancy to get your buy-in. So why are we doing this QI project? Why are we putting in the additional work? And finding ways to share that with clinicians. Another great one was identifying one key person who was going to champion that in each of your organizations. And some of you have made use in customizing your electronic records in order to make sure that you have consistent documentation along the way. And then another really good one was, they were all good, but another one that stuck out in my mind was hearing how you made this applicable on an interdisciplinary level so that you could capture even more patients and broaden your improvement. So congratulations to all of you for the really great work that you have done and for sharing that. We have a slide up here that shows our contact information. So you have the names of each of the New England QIN-QIO home health coordinators up on the screen and how to get a hold of us. And as I mentioned at the start of our program today, we're here to help facilitate and advance your QI work, so please don't hesitate to reach out to us, phone, email. We're here to help you. Next slide, please. Thank you. The In Case You Missed It newsletter. I wanted to just take a moment to remind everyone about our home health newsletter. We send this out the last Thursday of each month, and it will tie together for you important dates, events, information, and resources from the New England QIN-QIO, the HHQI, and the Million Hearts campaign. And then some of you are also participating in community care coalitions with providers in all settings of care and stakeholders who are looking towards safer transition. And so our newsletter also reports news and events for safer transitions initiatives. If you're not one of the home health agencies who's joined a coalition in your area, but you are interested in joining the important work going on, please contact your state home health lead that we just had on the last slide, and they can put you in touch with the Safer Transitions and Medication Safety Project leads. You'll also see their names and contact information on our monthly newsletter in the transition section. I think it's a wonderful way, even if you're only able to attend an occasional meeting or stay in touch via the correspondence. It's just a wonderful way to be able to share the voice of home health in this work, which I think we all hold as a mutual goal. Again, if you have any feedback for us for what you'd like to see in our newsletters, please let us know. Next slide, please. The next webinar is going to be held on May 11th from 12:30 to 1:30, and that is a new time period going forward from this point on. We used to have the 2 o'clock time slot, and I think that started back in the fall or January of 2015. And just recently, the last couple of months, we've had to move that time around. So we looked for a new slot that would be continuous going forward. So please make a note of that, save the date, and look for our invites coming out. We'd like to thank our panel who joined us today in providing this program. Michelle, Jennifer, and Alicia, thank you for your time and your generous support and willingness to share your experience today. We'd also like to thank Salisbury VNA, Cornerstone VNA, Community Health and Counseling Services, and all the home health agencies participating in the New England Collaborative for your commitment to improving cardiovascular health for your patients and for your communities. So much appreciation there to all the agencies and the staff for engaging in this with us. What I'd like to do is Georgette and I will put our heads together and we can document all of the great lessons learned and key takeaways from our conference call today and publish them on our website and send them out on a distribution if you like. So look for that to come out in the future so that we can make sure that everyone has an opportunity to share in all this great information and retain a lot of what was shared here. So we thank you very much for spending time with us today, and we look forward to our continued work with all of you.
Thanks, Doreen. I just want to thank everybody for a great discussion, and I just have a few last-minute announcements before we end the call today. When you close out of this webinar, the evaluation will automatically pop up in your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation as well as a link to the event page on our website. The PowerPoint presentation is already posted on our website. You should have received an email this morning so you could have followed along with the slides. And within the next few business days, a recording and a transcript will also be added. Be on the lookout for emails about our next webinar in May. Doreen's already spoken about the new time going forward for the foreseeable future. Thank you again for attending, and I hope you all have a great day. Thanks, everyone.